patient assessment the basis of everything? Because if you can't assess your patient, what can you do? So you have a primary assessment. A lot of times your primary assessment is sometimes labeled as a windshield assessment because I can walk in the door and look at you and do my primary assessment. Because I can tell from looking at you your level of consciousness, your airway, breathing, and circulation for the most part. Do you have it or do you not? Identifying life threats. Your vital functions. Vital functions are your ABCs. Can you walk? Can you talk? And an initial general impression. To me, an initial general impression is sick, not sick. So a lot of times when we're asking y'all for that, that's what we want you to tell you. Are they sick? Or are they not sick? So, 80-year-old grandma that fell from bed just needs help up. Sick, not sick. Can you walk in the door and look at her and see if she has her ABCs and her level of alertness and all that? Sure. 2-year-old febrile seizures. Sick, not sick.
More than likely sick.
More than likely sick. But you walked in the door and you were able to see if they had ABCs, what their level of consciousness was. Did you see any life threats? Are they bleeding out? Or is there anything impaled in them? Are they slumped over holding their chest? Their vital functions, talking to you, looking around, and your general impression. All of that. That's your primary assessment, and you walked in the door and saw it. You also can go ahead and begin any interventions needed to preserve life. This is oxygenation and stop bleeding for a lot of it. CPR, oxygen, stop bleeding. Those are initial assessments to preserve life. And then you can start doing some more treatment from there. History taking. This may be one of the most overlooked yet most important parts of your patient assessment. Finding out the patient's history. Now, this is their pertinent history. Someone that is 80 years old and having chest pain, it was not important to me that they had their tonsils out when they were 4. Unless there was some sort of issue with that caused a problem. But someone who's 80 years old and had hip surgery 3 days ago and has chest pain, that's important. You want to get what is their chief complaint. And this is what is the patient actually complaining of. I know that y'all have been on plenty of calls that whatever dispatch told you was the chief complaint was not the chief complaint. Sometimes that's because it was the thing that best fit. Sometimes that's because what they told dispatch is something totally different than what they're telling you. Sometimes it's just because it cookie crumbled that way. I hate to say it that way, but y'all, it's life, right? People do weird stuff, and we go help them.
When they tell dispatch one thing and it's nowhere near what it actually is.
Mm-hmm.
You get there and it's like, oh no, I'm just real dizzy, feel like I need to go to the hospital. You told them you were having a heart attack.
So a lot of times though, so the way our EMD works in Morgan County, someone that maybe just needs a lift assist, there's are you injured anywhere? And if someone says my bottom hurts, it can be marked as an injury and now it's a fall, not just a lift assist. Now, in the county with the volunteers, the ambulance is coming anyway until you cancel us. In the cities, like Hartsville and Decatur, if it's a lift assist only, the ambulance doesn't go unless the fire department gets on scene and requests them.
Morgan County is the exact opposite. They would not send an ambulance on.
You mean Marshall?
Marshall. Yeah.
What about Lawrence County?
Get them on the list.
What if you don't respond for a lift assist? Then who picks them up?
They pays out the next closest department.
And just until you.
Or just patient handling unit out.
Okay.
Polio ain't gonna
We-
be
hey.
bad.
I'm going to leave that one alone because I'm not going to win that fight.
We had to drive to the other side of Ruth at AWAB city limits for Lead Assist one day because no one from Ruth responded.
Yeah, we drove 30 minutes for what you said.
Yeah.
Wow. Mechanism of injury, nature of illness. So MOI, NOI, you'll see it abbreviated like that every now and then. Mechanism of injury is for trauma. Nature of illness is for medical. Associated signs and symptoms. Investigate the chief complaint, past medical history, and pertinent negatives. We're going to get deep dive into these in just a minute. Secondary assessment is your full body scan. A focused assessment of pain, assessment of vitals, and then techniques of physical examination. So like your respiratory system, this is where you're doing your breath sounds. This is where you're going to go ahead and check out your cardiovascular system, check their pulse. You're going to focus in on each individual body system in your secondary assessment, or the one that's they're complaining of. So you might be using a pulse ox, a blood pressure, a non-invasive blood pressure. So what it means by this is in the hospital, they might put in an arterial line, which is checking the blood pressure from inside the arteries. We're checking it on the outside. Now, as a medic, I can transport art lines and like connect my monitor to them and read them, but I cannot insert one, and I don't want to. Reassessment. Y'all remember how and when to reassess patients?
10 minutes?
For?
4?
No, 10 minutes for what type of patient?
Stable.
Stable. And how much for a critical patient?
3 to 5.
3 to 5. We usually go with 5 and 10. Maybe even 5 and 15 according to what it is. And you're always going to do at least one reassessment.
So a stable patient was what?
10.
Yeah.
And you're going to assess every patient. Even your lift assist, you're assessing them to make sure that they're really not hurt. Kind of. I mean, you're looking at them and making sure you don't see anything obvious. You're making sure they're alert when you get there.
I do have a question on this.
Okay.
I don't know if this is a Morgan County thing or a Brindley Mountain thing. 90% of these unconscious Delta calls that's coming in turn into overdoses. Is that a county-wide thing, or is that just something we
That's a
have?
nationwide thing.
Okay.
It might be a little more on the mountain, but it's kind of a nationwide thing.
Why are they not classified as cardiac respiratory death instead of unconscious? Fainting.
I'd have to go through and break down each individual.
Okay. I was just curious. I didn't know what
If
was
they're
on it.
breathing
Yeah.
when the call comes in, just because they're breathing when the call comes in doesn't mean they are when you get there. But if they're breathing when they come in, it's not a death. It's a fainting or an unresponsive. And if they don't tell us they did drugs, then how do you know it's an overdose?
Yes.
So, all right, there are 5 main parts of an assessment. Your scene size up, your primary assessment, history taking, secondary assessment, and reassessment. Scene size up starts at dispatch. What I mean by that is, you know when it's dispatched on X road, what you're expecting when you go to X road. You know your areas. I know that every one of you has at least one address that you recognize. Karma, if you're not responding with the department, you know at least one name that when it comes across the screen, who it is.
Yep. Are y'all giving a report? We know who it is.
So, yes.
It's right here.
Oh,
Sorry, I'm not trying to speed through. I'm just trying to hit the high points. So, symptoms and signs. Here's the big difference between a symptom and a sign. You can feel the symptom. I can see the sign. My chest hurts. You can feel that your chest hurts. I can see that you have bruising to your chest. Make sense? Yeah, they have fancy definitions, but think about symptoms are felt, signs are seen. I'll give you an example. I took a call at 911 for a patient having chest pain and difficulty breathing. They're giving me all the symptoms that this patient's having. Kavit, they left something out that you'll find out in a minute. So they're having chest pains and difficulty breathing. I'm thinking this person's having a heart attack. The fire department gets on scene. My fellow dispatcher stands up and says, Chrissy, do you know why they were having chest pains and difficulty breathing? And I said, no, I assumed they were having a heart attack. She said, no, they got stabbed. They left that part out.
Oh my gosh.
Apparently the person got stabbed in the back.
Quite literally.
And was having chest pain and difficulty breathing. He drove himself to a friend's house and never got out of the car. They never saw the blood until they moved him to get him out of the car. I'm thinking I would have told someone I got stabbed. He didn't, but hey.
He didn't want the cops showing up.
So, as we've said, your evaluation of the conditions in which you will be operating is your scene size up. Starts at dispatch. It's ever changing. Scenes do not stay the same. They change. It's an understanding of the situation and conditions prior to responding. So a day like today, you're dispatched to a wreck. Is that going to be different than responding to a wreck in July?
Yes.
Yes.
Oh yeah, especially because it's snowing.
Responding to someone's house during the day, is that different than responding to their house at night?
Yes.
I mean, those are some obvious things, right? You have to take in even something like this. Speaking doesn't have a school anymore, does it? Does it have?
They got the elementary.
Elementary. All right. You know when school hours are. So you know that getting to the fire department at X time is going to be harder. 3 o'clock in the afternoon is going to be harder to get to the fire department than 6 o'clock. Because correct me if I'm wrong, they're right there close together, right?
Yeah, it's right there.
Yeah, that's what I thought.
Just behind the fire department.
That's what I thought.
Just like Station 30, that was the stupidest place they could have put a station.
But going across 157 at 5 o'clock is like they've opened the
Right.
floodgates.
Yeah. Well, that's like getting out at New Center and 67 at 5 o'clock. It's almost impossible. I know that going to Huntsville at 5 o'clock in the afternoon, when you'd think it would be easier because everybody's leaving, there's more wrecks that happen on the way into Huntsville at 5 than there are on the way out of Huntsville. I don't understand it. Your dispatcher's basic information. Y'all know some dispatch areas actually say they'll give you road conditions and stuff?
Hey, Kristen, that's something you might want to bring up.
Well, I mean, if we're dispatching during a storm, I'll tell you, hey, there's a tree down on X road, you may need to look for an alternate route, or there's flooding on this road. If I'm at dispatch and I can provide that.
Some will, some won't.
Yeah. Well, and if you have the information too, I mean, that depends on it. And then your observation of the scene. That's outside, inside. One of the things that we were taught is look at the neighborhood. I know that sounds bad. We're taught not to profile, but at the same time, we're taught to profile. It goes back and forth. But you expect...
It's selective profiling.
You expect certain things from certain neighborhoods, correct?
Yeah.
There's a difference between responding to the gated subdivision and the trailer park with the calls that you may expect to run. That doesn't mean that there actually is any difference, but there's a difference between responding to Cherokee Ridge and that trailer park at the corner of Union Hill and 231.
Yeah.
I've responded to both. I know there's a difference in responding to those two.
Or Indian Hills and New Center.
I will say this: it's getting harder to do that.
It is getting harder.
Because for some reason in this county, y'all are building $1 million houses in the middle of Cracktopia.
It ain't a y'all.
Yeah.
Because I'm not building a $1 million house in the middle of Cracktopia. But y'all have the same thing going on. I mean, I've seen some of the houses out going up towards Bankhead. I've got some friends that I go through Speak to get to their house because where they live in Bankhead. They have like a little rinky-dink cabin, and across the street is this big fancy thing. And I'm like, why'd you build that house here? Makes no sense. I don't go to Athens enough to know how bad their housing is.
About the same.
Going up right there in the Bankhead, that's kind of a rough area. Just FYI.
Yeah.
FYI. Yeah.
Yeah, but I got some friends that live, like, we have to go up that way to get to them. They live
But
out.
once you get past it, you're good. It's
Yeah.
just that little. Right
They
there at
they
the
live up
bottom.
in next to one of the horse camps.
I
They've
got
got some cabins up there. And he's Cherokee, so he really is bare bones on some things. Issues can range from minor difficulties to major dangers. So, muddy driveway as opposed to
Concrete.
road traffic. One is a minor difficulty, one's a major danger, right? Now, the question is which one of those is which, because in some instances those muddy driveways are major dangers, because if you can't get up it, how do you get the patient down it? Do not enter the scene until the scene is safe for you and your team. Do not enter the scene until it is safe. Just because police is on scene does not mean it is safe. Do not follow the police car to the scene.
Personal experience.
Your old boss. Never mind.
It
We will
happens.
not video retaping.
It happens. Drives me insane. Just because police are there doesn't mean it's safe. Y'all, I've had PD tell me the scene is safe and get shot at. Because someone drove by and shot. I've also been on a scene that they said is safe, and the person that they thought was unresponsive over here sits up and goes, "Hey, what are y'all doing in my house?" Scene safety is ever changing, and you need to wait until something has been cleared before you respond. While we're on that, again, staging is not at the end of the driveway. It's one of my pet peeves because it's something that could get someone hurt, and it's something easily fixed. Typically, the way you enter an area is the way you will leave. You know, pay attention to how you got there so you know how to get back out. We all know that some places our GPSs do not work. You two are even worse than y'all will be. Because I know where both of y'all are responding, and I know that sometimes it's hell or high water if the GPS is going to work or if it's going to get you to the right spot.
Or if you even get the right address.
Well, and both of you have to respond. You do too, because you've got the refuge.
Yeah.
But GPS coordinates may be what you're getting. I feel like someone said, may the odds be ever in your favor.
Cherokee Ridge is on.
If
Do
I
you
look at
have
the phone,
areas like that? Or
if I look at my phone and it says Truck Trail Road, I'm already thinking,
which one?
all right, are we starting at the Decatur side or what? Or
Yeah,
am I going
so-
all the way to Kentucky? Where am I
Right.
going?
I mean,
Cherokee Ridge is doubling in size now.
Oh.
So all their roads.
it
are
was
not
bad
on
enough
Google
when it
Maps.
wasn't.
Like they're now down to the $250,000
Well,
home range.
And
going on
then,
top of each
you know, let's look at some stuff like this too. There are some subdivisions that there really is only one way in and one way out. And I mean, in Decatur, there are some places that you have to drive around the block to be able to get out. Because that's,
You
One
get
way
turned
road.
around in a subdivision if you ain't careful.
yes. I will tell y'all, I've worked Decatur for 20 years. I still get lost going over into Point Mallard Estates, the rich side of town. Still get lost.
Oh, there next point now? Oh yeah, I do too. And I used to work over there at GE, and I had to know every way in and out of there in case traffic was bad.
Mm-hmm. Wear a high visibility safety vest on roadways. They should be in the ambulance. You should have them on your fire trucks. Or in your personal gear that your department gave you. You know where we messed this up? When we respond POV and we don't have them. Because like if you leave it with your turnouts and you left your turnouts at the station and you responded POV, we've all done it.
I've got to gripe at y'all for doing this because Decatur Morgan's bad about this. We will have the roadway completely opened up, and then y'all pull in the ambulance, leave the ambulance in the middle of the highway.
That's part of their job.
No, not whenever there's 50 foot of shoulder over here. There's 50 foot of open shoulder space.
Some of these people are city folks. They're still getting used to working in the county. Consider difficult terrain. We've got that here. Consider traffic safety issues. We've all run those calls. And we know that rubberneckers are much more dangerous than anybody that's paying attention. Environmental conditions. Y'all, it's cold today. It may not be raining. But did what you wear here, is that going to last you on a wreck scene? Absolutely not. Y'all, when I go to work, I dress like I'm going to be in the weather. I can take my jacket off. I can take 2 or 3 jackets off. But like tomorrow night, when they say the wind chill is going to be 2, and I'm going to have to work in it, I will probably have a couple pair of leggings on, and a long sleeve shirt, and a couple jackets with me, and something to protect my ears. Just because if I do have to get out in that, I have to take care of a patient afterwards. And I don't get to warm it. Like, I have to be able to immediately do it. So I have to dress like I'm going to be in that weather. Same thing for the summertime. As light as I can. I have different shoes for summer and winter. It's just how it is. If appropriate, help protect bystanders from becoming patients. Random people do not get to walk in the house. The people that stopped to help, I'm here now. I appreciate you staying to help. Can you get in your car? The police may want to talk to you. But we don't want random people walking around the side of the road. Hazards can be anything from weather to physical violence. Always know where your exits are and try not to let anyone walk in behind you. One of the things that gets me, and I feel like this happens more in Decatur than it does in the county. I could be wrong. But we'll respond somewhere and we'll have 3 or 4 of the neighbors just walk into the house. Is everything okay? Who are you? Do you live here? Then can you please leave? It can get, there are certain parts of town that can be very hostile. And remember that it's a dynamically changing environment. Your scene is constantly changing. Whether because you did something or didn't do something, or somebody showed up, or police showed up, or the weather changed. Day like today is not bad. What if it starts raining? Does that just make everything a whole lot more worse?
Oh, if it starts raining today, it's going to be.
Yeah. We're on a wreck scene and it starts raining.
Well,
Situation just changed drastically, right?
especially if it's flooding and the car's upside down in the ditch.
Well, think about the people that are driving that are rubbernecking and it started to rain and now they're sliding into you. Because it's cold enough. Like the roads may actually be cold enough to ice. I don't know. Some of these back roads will be. The main roads, no. But some of the back roads, I fully expect ice on some of them if it starts to rain. So determine your mechanism of injury and nature of illness. When you get there, what do you see? Mechanism of injury, type or amount of force. How long was it applied? Where was it applied to the body? What's worse, a wreck with entrapment or a wreck with ejection?
Ejection. Or they're both probably equal.
They're about equal. Because entrapment, you could have one that slid at 90 miles an hour, and the driver's door slid into a tree at 90 miles an hour. So your entrapment is 90 miles an hour against a tree or a telephone pole. Whereas the ejection could have been they were running 5 miles an hour and they got hit from the other side with somebody running 10, 15 and got thrown out the driver's window.
It'd be the nature of the call.
It'd be the nature
You
of the
have
call.
to just read that.
Well, and it's also going to be, how are they entrapped? Are they entrapped because they can't open the door? Or are they entrapped because the dash is rolled down on them? And is it a full or partial ejection? Were they ejected because they were driving a Jeep without doors? Or were they ejected out of front windshield? So, but those are things to look at, as in, how bad was this? Blunt trauma, force occurs over a broad area. The skin is usually not broken. The tissues and organs below the area of impact may be damaged. So, here's something to think about when we were talking about the ejection versus entrapment. A lot of times your ejected people will have both blunt and penetrating trauma. Because they will have been cut by something, windshield or something like that. A lot of times if they're entrapped, they're only going to have that blunt trauma. Now, I'm not saying that one is better than the other, but you may have even more injuries.
Another thing about it, entrapment too, and correct me if I'm wrong on this, is just because they're trapped inside a vehicle doesn't mean, like you said, the dash can roll down on them. Well, if the dash is roll down on them, the car's still flipping. That's having their torso and their head just swinging around.
According to how well their seatbelts work.
If they were wearing their seatbelts.
Right. So, and open wounds have high potential for infection. We can treat infections, but infections, more honestly, people tend to die not from the injury, but from the infection after it. I'm not saying people don't die from the injuries, but a lot of people, the infection they get afterwards is what actually. All right, so nature of illness is for your medical patients. There are a lot of similarities. The big difference, though, is that mechanism is a force. Nature is something that occurred. Talk with your patients, family, or bystanders. Use sentences to check for clues. What would be a clue that you would use your senses for?
Are you saying like when you roll up on a scene?
So this is a medical scene.
Yeah.
Well, yeah, you're on scene and there's somebody sick. Something.
Carbon dioxide.
Carbon dioxide. What would be something you would think you would see with carbon dioxide? Because you're not necessarily going to smell anything with carbon monoxide.
You can pay attention to the plants around. The plants in the room would be yellow.
Possibly.
They could be sick. Like.
How about just the fact that it's this time of year and they've got the heater going? Is that something that's going to make you... Fireplace or a gas heater. Those tend to be... What about you smell that sulfur, that egg smell? You're going to lean towards possible gas causing it. More than one person in the house is sick. What about just something as simple as you go in and they're wrapped up in 15 blankets and still say they're cold? Well, I'm going to think they have a fever. My question is, do they have a fever because they're wrapped up in the blankets, or are they wrapped in the blankets because they have a fever? I make mom and dad mad a lot because I will strip the baby down to the diaper. I'll put a blanket over them, take them out to the truck, but once we get in the truck, a lot of times I take the blanket off because we don't want to make the temperature go up anymore. Febrile seizures are a thing, and they're not a good thing. Again, be aware of signs of... if you have more than one sign or symptom, more than one or patient sick, because that means there could be something in the house and you could become the patient. Considering the MOI or NOI early can be of value in preparing to care for the patient. So again, when we're dispatched, we're kind of considering what we may be rolling up on, right? You're going to think, if you're dispatched to a chest pain, all right, here's some things that could be wrong. These are some things I may need to do. Whereas opposed to if I respond to a wreck, this could be what's wrong. This is what I got to do. Here's one of the hard parts for those of you that are firefighters as well. When you get there, what role are you in? Are you the firefighter today, or are you the EMT today? And that could change day to day.
Change call to call.
I guess
Change call to call.
I mean, it could be both. Though.
It could be both. Are you one until someone can get there? And then you become the other? Are you both until someone can get there to take over one or the other? Absolutely. Same thing on the ambulance, but sometimes, there's less we can do on the ambulance to a certain extent than you can do. If you roll the engine, you might have to fight the fire until someone can get there to take over that while you take care of the patient. All right, standard precautions, PPE. Adapted to the pre-hospital task at hand. At a minimum, you should probably be wearing gloves. You're protecting not just yourself, but your patient. Think about it. Carmen, I'm going to pick on you for a minute. You've been coughing and everything. The glove is to protect your patient from your cold as much as it is to protect you from anything they may have going on. Does that mean I wear gloves with every single patient? Sometimes I touch them before I put my gloves on. Because how else am I going to know what their skin condition is? But I have gloves in my pocket to put on for when they're needed.
It's not like you touch them, they're gonna start disintegrating, but same time, you gotta be careful with what you're doing.
Yeah. I mean, if they've got blood all over them, I'm putting my gloves on before I touch them.
Yeah.
But grandma that is calling me for her difficulty breathing, I may want to go in and see if she's got a temperature or if she's clammy or anything like that before I necessarily put my gloves on.
Chicken coop, I ain't going to it.
Chicken. Oh God, no.
You're protecting yourself from bodily fluids, objects. Somebody might still have the needle sticking out of their arm. We do not have to wear masks on every call now, but you are given the option to wear a mask. And again, sometimes the mask is because you're coughing, not necessarily because the patient is. I'll tell you personally, I hate masks. If you don't have on like one of the N95 masks, it's not really protecting anybody, but whatever. You do what makes you feel comfortable in that instance. When you step out of the EMS vehicle, standard precautions must have been already taken. At a minimum, your gloves. Possibly glasses or a mask if you need it. I will tell you, I worked for an ambulance service that made us wear helmets with face shields. I had never been so happy to have that face shield one night as the night that I ran a patient with a nosebleed. Nosebleed, right? That's nothing. Yeah. She'd also got drunk and snorted crack before she got punched in the nose. That's what caused the nosebleed. It wouldn't stop, and about the time I'd get it to claw it off, she'd blow her nose across the back of the truck. I was quite happy to have my face shield that night, y'all. So you may need it. Our OB kits have gowns in them, so you can gown up before you deliver a baby. Those of you that have been present when children are delivered, is it a clean? No. You may be happy to have that gown if you're actually delivering a baby. During the scene size up, identify the total number of patients. How many patients can you yourself handle? Depends on the severity. Because if I've got a couple patients that have been in a fender bender and just have a little bit of back pain and want to go to the hospital to get checked out, is that different than me having a couple patients who have broken bones and things like that?
Yes.
Yeah.
One corrector.
So what is the actual span of control on patients? Is there anything written in the book on that?
It depends upon severity and your resources.
Let's say it's a fender bender. All you're doing is monitoring vital signs at the hospital.
2, 3.
Okay.
I mean.
Now, don't put 2 or 3 patients in the back of the rig unless it's like a 13-car pileup.
Why? Why couldn't I take 2 patients from the same vehicle that just want to go?
If it's the same
We try not to put different vehicles in the back of the same ambulance.
That's what I meant. That's what
Yeah,
I meant.
yeah.
Like,
But
three
like,
different cars,
right.
3 different people.
Yeah.
They're gonna be bitching at each other all the way.
But like if you and Izzy have a wreck, I can put you both in the same ambulance. That may actually not be the best thing in the world to do if you're arguing with your spouse about who caused the wreck. But you'll get my point on that. That would be different than me putting... What are you looking at me for? But y'all see what I'm saying? There's not necessarily a defined number.
Okay.
But, and I'll even say it this way. What you as a new EMT may consider the max of your capacity and what me as a paramedic with the years of experience I've got could be very different. And I don't say that as a bad thing, because you're going to build up to feeling more comfortable taking on more.
I can't believe it's just the gray areas. How big these gray areas get is fun.
Are they not that gray in firefighting?
No, not to this. Not to this extent. They're gray, but not this.
How gray are they in the hospital compared to this?
Very, very.
Yeah, it's a medical thing.
It's a medical.
Yeah.
Like firefighter, span of control, lieutenants can have 3 or 4 people under them.
So I will tell you that Decatur Fire just added another battalion chief because they're saying the span of control is 6 and they have 8 departments. So the battalion chief, they've divided 4 and 4 for right now. I don't know because it's for each shift, and I don't know who got promoted for each shift. Our supervisors, 4 to 5 trucks, is what they manage. So it depends. Incident command for EMS is the same as incident command for fire in some ways. The system is the same. Triaging is different because we're medical triaging, and y'all are the equivalent to triage. I could think would be like severity of burns. Like when you roll up on scene, you're like, we have smoke showing, there's flames showing on the A side, there's this on the B side. That's about like me pulling up on scene and going, hey, Central, I have 3 patients, 2 of them are critical, 1 of them's non-critical, and 1's deceased. That's the closest similarity I can get between fire and EMS in that instance. There may be something that's a little bit closer, but that's the closest I can get. Scene size up is scene size up. Just what you're looking at is a little different. Y'all respond to Rex. Y'all pull up on scene and at least at a minimum say, hey, dispatch, I'm on scene. We've got 3 cars, 1 with entrapment, 2 with minor injuries. Something like that, right?
I have number one lane block on both sides of it.
See, but I mean, that's the kind of thing. And so you married fire and EMS when you did that.
Yeah, I know. She's right there.
No, I made fire and EMS, and I moved to Morgan County. DeKalb County, I was fires only. We didn't even do vehicle accidents. Thank you very much.
Huh?
We had a rescue squad.
You may need more ambulances. You may need specialized resources. So, specialized resources. I will tell you, we are very lucky in Morgan County that we do have our auto launch criteria.
Thank God.
Now, could that be adjusted some? It could. Does that mean I'm not going to ask for a helicopter if I think I need one? No. Does Lawrence County have auto launch criteria?
It depends on the severity.
Okay.
So like I think they auto launch if it's an entrapment or anything like that.
Okay.
Limestone County does.
Limestone County does. Does Marshall County have auto launch?
They said we're too close to Huntsville, but that's a waste of time.
What if it's a burn that needs to go to Birmingham? What if you have a 45-minute extrication?
I'm with you.
I think in Morgan County, it's falls over 20 feet, wrecks with ejection. All motorcycle wrecks are considered a wreck with ejection, so they are auto-launched. Burns.
Rollovers in Limestone is considered a auto launch.
I think rollovers maybe if not, wrecks with entrapment. So ejection and entrapment both would get
There's
it.
some medical that's
We've
Oh,
considered
if I'm not
adding
mistaken.
strokes to it, but we haven't.
but I don't remember.
I'm pretty sure rollovers, even though they might be able to crawl out the window, they're considered. I don't know if you dispatched it like this, but I know when I've responded to a rollover,
A lot of times
entrapment.
a lot of times they go ahead and auto launch those, and because the helicopters would rather be on the way and canceled than not. Shootings tend to get it, stabbings tend to get it. Tends to be more trauma than medical, I will say that. Though we have considered adding strokes. Lauderdale County auto launched on cardiac arrests at one point, and I was like, why are we auto launching on cardiac arrests? And this was pre-Lucas, y'all. Pre-Lucas. Well, some of their reasoning behind that was if you got ROSC, they would rather be on the way because Lauderdale to Huntsville was better than. And I understood that, but at the same time, it didn't make. It was one of those that kind of made sense and kind of didn't at the same time. But you may need advanced life support. Y'all are responding on a basic unit. There's nothing wrong with calling for help. You may need that air medical. You may need more fire departments, because what if you need high angle rescue? Do you know which fire department to call? What if you need hazmat?
Decatur.
Decatur's pretty much it in this area.
Huntsville.
Y'all get Huntsville.
We get Huntsville.
Decatur or Faultville, because Faultville's got a hazmat.
Falkville is, Falkville's getting some hazmat stuff now. High angle rescue, we tend to call Brindley Mountain, or at least we used to, in Morgan County. Who do y'all call?
For
High angle rescue.
I think it's gonna be Decatur or Danville. They got a ladder truck, stuff like that.
Water rescue, we tend to call out the rescue squad. because they've got the boats and everything.
Or,
Y'all
yeah.
are the same way on
Yeah.
that. I'm assuming Limestone County's the same way with whoever's got the boat.
Depending on where it's at.
So, ways to consider if you need additional resources. Does the scene pose a threat to me, my patient, or others? Because then you know you're going to need law enforcement, right? How many patients are there? If it's you and you have 2 patients and they're not critical, you could probably handle 2 patients. 3 might tax you. Honestly, I don't like to carry more than 2 if I can help it. I have carried like a mom and 2 children or something like that. Because I do try to keep families together if I can. Makes sense, right?
You put them in different ambulances, there ain't no telling
Right.
where they're gonna end up hospital.
Well, here's a fun thing. You can put them in the same ambulance and they'll still make you take mom to Maine and children to Children's at Huntsville. Try explaining that to a mama. Yeah.
Even with that being women's and children's, like,
If it's a trauma, adults go to Maine,
yeah.
children go to Children's. Yeah. I had a wreck with fatality where I transported dad and the son that lived, and when he found out he was being separated from his son, it was bad.
Ooh, shit.
And I didn't know they hadn't told him when they put him in my ambulance. Because we were the backup ambulance. This was actually a Huntsville call. And we were coming back from a transport to Huntsville, and they needed another ambulance. And we were, like, passing by the scene. So they asked us to go back to it. First of all, they didn't tell me there had been a fatality in the car.
Damn.
And it was the mom, right?
No, it was the other son.
The other side.
Oh, that's worse.
Yeah. Mom was in critical condition, had already been transported. Dad wasn't hurt. But Dad had been the one driving. He got hit by another vehicle. It was not his fault, but one of his children died when his wife was in critical condition.
Yeah. Oh yeah.
And his other son is.
Not that bad. We were just going because there had been a fatality and he needed to be checked out, but no one told me there was a fatality.
Damn.
And now I have to take Dad to Maine and child to Children's.
That's when I look at him and be like, nope, it's yours.
I told the doctor that he could explain it when I got there.
Yeah.
Because I told my partner, I was like, I need you to go in and get me the charge nurse. We didn't even get out of the truck until the charge nurse came out, and I made her explain it. Because I didn't know what else to do at that point.
Oh yeah.
I mean, use your resources. And then another thing is, do you have the resources for their condition? So, as a basic unit, do you have the resources to treat the patient? That'll tell you if you need ALS or not, too. Your primary assessment begins when you greet your patient. The goal is to identify and initiate treatment of immediate or potential life threats. You can tell if someone's bleeding out. You can tell if someone's not breathing. Those are big factors if they've got life threats. Physically examine and look at their LOC. What is their level of consciousness? Now, I do want to point out that sometimes their level of consciousness may be their normal. But we're looking more at level of consciousness than mental status in this. However, y'all, you may respond to a hospice patient who doesn't respond. That may be normal for them. You do need to find that out. What are their ABCs? Airway, breathing, circulation. Are they breathing correctly? Do they have a patent airway? Do they have a pulse? Those are very important to know. Alright. Your general impression. Your general impression is kind of that sick, not sick, right? It's the first part of your assessment. You want to kind of look at them and make note of their age, sex, and race. Why is race important?
Because it's 2024, 2025. People get offended easily.
Alabama still, so you know.
No,
They're
certain ethnicities and races have different health complications due to where they're from, their background. Like some people are more susceptible to certain types of.
Example tends to be the African American community that has sickle cell disease.
Yeah, that.
So
I knew it was something, but I couldn't remember.
that
the name.
Now, you may run into also with race some cultural things, like may not want a male to examine a female, something like that. But we're looking at,
And also, translation issues.
yes, but we're looking at, and for this instance, treatment wise, because a certain race may have a problem that a different one might not. Sex, here's the, this is where it gets a little bit difficult sometimes.
Now,
For the purposes of medical treatment, it's biological sex, what you were born as. Sometimes that's easier to tell than others.
Yeah.
I will tell y'all, I have a friend that has transitioned. If I hadn't known him before he was a he, like if I hadn't known him when he was a she, I wouldn't know he had ever been a she.
damn.
That's confusing.
Because I knew him before he transitioned,
Yeah.
I know that he was a female. But he has transitioned, like took the meds, did the surgeries and stuff like that. You wouldn't tell. But he still has female internal organs. So, it's 2025. A male can be pregnant.
She just blew my mind.
I don't necessarily agree with that statement, but
So would would their driver's license then say?
Well,
Sometimes their driver's license will change.
mhm.
where does the
If-
baby
Change
come
their
out of?
license.
Because they have surgery. If they've had surgery and they have the added,
But she said that it was a girl that turned into a guy.
Mhm.
yeah.
So-
But they've
so
had
if you-
surgery, so they
lot
have
of
a
time- lot
thing
of
now.
times when female to male has bottom surgery, they also have a hysterectomy.
But you could
Okay.
also do a C-section.
Okay.
I just got deep real quick.
Glad I'm wearing my boots today.
I was just curious because
If you're a girl and you transfer to a man, you still got a vagina, which means you can get.
Not if you've had the surgery.
Well,
Not if you've had
and this
bottom
one's had the
surgery.
surgery, so it has a.
so they added.
Yeah.
Typically,
Now you see where I was coming from.
I didn't say this person. Typically, if they go to this trouble to have that surgery, they have the hysterectomy too.
Okay.
Yeah.
And then when the old lady started asking, why are you looking this up? It's for class!
Y'all, it's situations we may run into. Someone may be offended because you call him her or her him. I've been yelled at for saying ma'am and sir. Not necessarily because they transitioned, but because they didn't want to be called ma'am or sir. Yeah.
And then you get, well, what do you call
Yeah, I mean, sweetie, darling, dear works for both sexes,
Yeah.
y'all.
It's-
All of it, I'll walk up and say, how you doing, friend? What's up?
Yeah, I mean,
Friend is
look, it's awful.
A good indicator to
there's
double
no
check.
indicator.
No, a good indicator like on a car wreck or something like that is if you see all those flag stickers on the back of the car.
Yeah, I got you.
That's a good question to ask.
Not in every circumstance, but we're seeing it more and more. When I went through EMT, this was not a discussion we had. It just wasn't a discussion we had.
When
This
I went-
wasn't a thing.
When I went through EMT 3 years ago now, I think, we actually watched the surgery online. Like, there was a YouTube video of me watched the surgery.
I'm not gonna have y'all watch the
So
surgery.
I just need to.
Well,
just
you
tell me
also got to
this.
think. You also got to think.
Okay.
She went through EMT school in Atlanta. There's
Yeah.
a lot more of that in
Yeah, she's a
Atlanta
lot more
than
liberal
is
than
here.
we are over here.
So if they add tools to the toolbox, does that mean that they've got 2 tools in the toolbox, or do they take care of the other one?
I didn't think about that. That's actually
No, when
pretty
you
solid.
have- when a female to male has bottom surgery, and they also get the hysterectomy.
They typically get the hysterectomy if they're gonna go to the.
I get that.
Yeah.
So they don't have both tools in the toolbox. They have one or the other.
Yeah.
So they stitch it all up.
Yes.
That's what I needed to know. Thank you.
The fun.
He was about to have a stroke in the middle of class.
Y'all just freaking I haven't really looked that deep into that stuff.
I mean,
Never.
sadly, it is the times that we're in. So
We're running
medical
these
side of
calls
things,
now
we have to
where,
be able to
I mean,
go with it.
I haven't run it here, but I have talked to people in other states that have run pregnant males. And I'm like, no, they're a female if they're pregnant. And they're like, but they identify as a male. I was like, I don't care. Babies don't push men out. But, I mean,
Maybe don't push me out.
y'all know what I meant.
We done got it worked up. You know.
Yeah, it's a sensitive subject. And we kind of, I don't want to say we're taking it lightly. I think we're having to laugh at it a little bit because it's such a deep subject that it's hard to wrap your head around.
And don't be scared to ask someone, like, if you genuinely don't know, how do you identify? They would rather you
because-
ask them
well,
than assume
A
something.
lot of them will tell you, especially if they're sick. Now, did you ever meet? I don't want to be recorded.
Yes.
Yeah, he confused me. Whatever. But most will tell you. Most are not, in this area at least, are not argumentative. It's not like what you see on TV where they're marching on the Capitol with vagina hats on.
Around here, they're a little more understanding.
They are a little bit more.
Yeah. They'll just tell you, like,
They will typically tell you, they will say if they're having anything. A lot of them will say, hey, I'm transitioning, I started a new med, or I did this or that or the other, and you'll know that might be what led to it.
Especially if it's transition sickness with like
With the meds or
testosterone
something like that,
or
yeah.
they will definitely let you know that.
The only problem you're going to have with it is if you have like a unconscious person in a wreck or something like that, that may be where some of the issues come in. But most of the treatments we do don't make that much of a difference pre-hospital. Note the patient's position. How do you find them? Are they laying in bed? Are they curled up under the car? Avoid standing over the patient. I will tell y'all, standing over a patient, because of a bad experience I had, I ran a rape patient that was unconscious, and when she woke up, there was a firefighter standing over her, straddling her like her assailant had just done. I usually am able to keep my cool on scene. I lost my crap. I kicked a firefighter off the scene, almost physically, filed a complaint with his lieutenant, his battalion chief, and like his EMS captain. Because it bothered me so much, because she came to with a man straddling her, standing over her. You got to be cognizant of where you're at.
Well, I mean, it's also situational because I mean, what if
Why
you're
would you
trying-
ever stand? What I mean by standing over a patient is literally not you're lifting them or anything
That's
like
what I'm
that.
talking about.
That's
If they-
different. If
they
you're
come to while you're trying to
That's
get in
different.
position,
I'm saying you're doing it in almost an intimidating fashion, because whether you mean to or not, that's how it comes across. Any of y'all done body language studies? Did you have to do any in school? We've had to do some body language. Did you have to do any at the hospital or anything, body language studies?
Probably, I don't know.
Okay. They made us do some, and I've had to do some in some of my. The way you stand and the way people interpret it, like standing like this is actually, I don't give a crap about you, or aggressive.
I did do it when I worked at the jail.
So the way you approach someone, they're reading you just like we're reading them, right? So standing over someone is an aggressive action, whether you mean it to be or not. Address the patient by name, whatever name they want you to call them. And what I mean by that is somebody's name may be Sarah, and she wants to be called Rah or something like that, because that's what her grandchildren have called her, and that's what. Or all right, Mike. His name's Michael. He wants to be called Mike. That's not uncommon, right? Call the patient what they want to be called. Within reason, you're not going to call them a cuss name or anything like that. I've had some patients say you should call me this, and I'm not going to call you that, but y'all know what I mean. Introduce yourself. I will tell you, this is where I slack. I'm really bad about not introducing myself immediately like I should. Sometimes I might say I'm with the ambulance, but I don't tell you my name. Really bad about that.
I'll just say EMS. And
Ask about the chief complaint. Hey, what's going on today? Why am I here? Why'd you call me? Politely. Remember, your tone of voice transmits as much as your words. Address life threats immediately and determine if the patient is stable, unstable, potentially unstable. Uncontrolled external bleeding takes priority over other assessments. Uncontrolled. Someone that has a small cut that's oozing is not uncontrolled. Someone that's got an artery that's shooting across the room is uncontrolled. Level of consciousness. So you want to know their neurological and physiological status. It's just a fire alarm.
It's showing keypad like somebody hit it.
Assessment of unconscious patients focus on airway, breathing, and circulation. LOC is pretty much awake, not awake. Sustained unconsciousness should warn you of a critical problem. You shouldn't remain unconscious. Conscious but altered may be due to inadequate perfusion. So you can be conscious and awake, but think it's 2000. You're altered. Could be caused by medications, drugs, alcohol, or poisoning. Something to look at is, especially in the elderly, how many of the same medications do they have? And have they taken them all? Different pharmacies, or they have different dosages, or they get them by mail order. They didn't take this one correctly. They got a new one in, so now they're taking both. Younger people do it too, but it happens more in the elderly. So assess for awake and alert, responsive to verbal stimuli only, responsive to painful stimuli only, or unresponsive. That's your AVPU, and that is your LOC assessment. Hopefully those are on that mnemonics page for you as well. To test responsiveness, a couple of different ways. You can do a sternal rub. You can pinch the cheek or the earlobe. Pinch the trapezoid area. My brother has one that he's pretty accurate with. Someone's not going to let you poke them in the eye. So you can pull back the eyelid and go like you're going to touch. If someone's faking, sometimes they can fake through this stuff. You're typically not going to fake through being poked in the eye.
You ain't gonna fake ammonia caps either.
Most places don't carry those anymore. Orientation, test mental status, person, place, time, event. This is our who are you, where are you, what year is it, what day is it, who's the president, how many quarters make a dollar. Evaluates long-term memory, immediate-term memory, and short-term memory. Altered mental status is they cannot answer those. Person, place, time, event. If they can't answer any of that, they're not, they're altered. And if it's any deviation from the patient's normal baseline. So your dementia patient that normally knows who he is and who his family is and doesn't know who anybody is, doesn't recognize where he's at and normally does, they are altered. Like we said, dementia patients are always altered. Are they more altered than normal? Conditions that cause sudden death. You want to treat these immediately. Airway obstructions, respiratory failure, respiratory arrest, shock, severe bleeding, cardiac arrest. If someone's in those, we're not worried as much about history beyond do we know what caused it. So back to, did they overdose? Did you see them take anything? Why are they in shock? Are they bleeding? Unless, those type of things. In most cases, you're still going to start with your airway, breathing, and circulation. However, some of them you may do circulation, airway, breathing. So like your patient that's bleeding out, that's circulatory. We're going to take over circulation issues first. Moving through the primary assessment, stay alert for signs of airway obstruction. Ensure the airway remains open and adequate. If they are talking or crying, they have an open airway. Just keep watching them to make sure they don't lose it. Unresponsive patients, immediately assess that airway. Use jaw thrust technique when necessary. So our trauma patients get jaw thrust. Non-trauma get head tilt, chin lift, because you want to relax the tongue to get it away so it's not causing an airway obstruction. Obvious trauma, blood, or obstruction, obviously are causing problems. If something's in the airway when you look, get it out. Noisy breathing. It's an airway obstruction. You know people that snore have obstructed airways? That's what sleep apnea is. That's why they wear CPAPs. It opens up the airway. Extremely shallow or absent breathing. Those are all signs of airway obstruction. Make sure the airway is open and that they are breathing. Now, here's a question. Someone that's breathing 3 times a minute, are they adequately breathing?
No.
Someone that's breathing 40 times a minute, are they adequately breathing? No. Not unless they've just run a marathon. If they are breathing but they're blue, are they adequately breathing? No. Consider providing positive pressure ventilations with an airway adjunct when respirations are more than 28 or less than 8. More than 28 or less than 8, you need a BVM. Or you should consider a BVM. And our oxygen goal is 94 to 99%. Most people aren't at 100%. But you aim for 94 to 99. There are a few exceptions. A COPD patient may be lower, but they'll be able to tell you what their normal O2 sats are. Observe how much effort is required for the patient to breathe. Do they have retractions? So when they breathe in, is their chest and ribs like going in so much that they look almost flat? Are they using accessory muscles, or is there extra muscles being used? Nasal flaring, that nostrils are flaring out. 2 to 3 word dyspnea, which is the short word sentences. I can't breathe. Help me. Those are obvious signs. Tripod position. That tripod position is where you're sitting down and they're kind of like this, holding themselves up. That's tripod. Sniffing position is where they've got their nose up and they're trying to breathe more, or just labored breathing in general. If someone is sitting in a chair and breathing like they've just run a marathon, that's not good. Do they have any work of breathing? Are they breathing harder, faster, longer? Increased effort and rate. Respiratory failure occurs when the blood is inadequately oxygenated or ventilation is inadequate to meet the oxygen demands of the body. So they're trying to breathe and it's just not enough. For whatever reason. The ultimate result of respiratory failure if it is not corrected. So when you're assessing circulation, you're assessing their mental status. Why? What will your mental status tell you about circulation?
They're, what do they call that? Hypoxia?
They might be hypoxic.
Hypoxia.
They may be breathing, but it's just not enough. They're not circulating enough blood, so they're not circulating enough oxygen. What is their pulse? Weak, thready, strong, normal. Skin condition, pale, cool, dry. What's your normal skin condition? If their skin doesn't look similar to yours, there's probably a problem. Know that some people are more pale than others. We know this. Some are more tan than others. When a black person is white, there's a problem. That sounds bad, but when they're a darker skinned person and around their lips and their nail beds and stuff is like white, obviously there's a problem there, right? The pulse is a pressure wave that occurs as each heartbeat causes a surge in the blood circulating through the arteries. So you want to feel the pulse. Can you find your own pulse? If you can find it on yourself, you can usually find it on someone else. If you cannot palpate a pulse in an unresponsive patient, begin CPR. Now remember, unresponsive, we want to go carotid. Other patients, we're going to go radial. I will tell you, a lot of times when I'm doing my assessments, I will come in, I'll be like, hey, I'm Christy with the ambulance service. How are you today? I've got a hand here and a hand here. As I do this, I'm checking a pulse and their respirations and their body temperature. I try not to lean over them like that, but y'all get my point. You can do a lot in that 5 seconds that it took you to put your hand on. I'm not necessarily checking to see how fast it is. I'm checking to see if they have a pulse in that instance. And then I'll take efforts to go in and see fast, slow, whatever. As we said, skin color, we want it to be pinkish. A good color, like a normal skin color. Skin temperature, you want it to be warm. Now, we just walked in from outside. Are we necessarily going to be warm? No. But you don't want to be icy either. Dry skin is normal. Skin that is wet, moist, or excessively dry and hot suggests a skin problem. So how you are right now is normal. That's a dry skin. What they mean by excessively dry is that peeling skin or the really hot to the touch. Y'all know the difference between like this dry and like dry. You'll know it when you feel it. I don't know a better way to describe it. Cap refill, that is when you squeeze the nail bed and let go. How long does it take to return the blood? It should take 2 seconds or less. And there's just an example of cap refill. We do this a lot on babies. Babies that are like too small to get a blood pressure on, cap refill is a good thing for them. Assess and control external bleeding in trauma patients. Apply direct pressure or a tourniquet if needed. That typically stops it. Remember, it's you can't put a tourniquet on anything but an extremity. Can't put it on the neck. We don't have the ones that you can put on the abdomen. The military has them, but we don't. A rapid exam, that's quick. I looked at you, I touched you, you have a pulse, you are breathing, your skin's normal. Took me 60 seconds to do all that. And this is where you're going to determine priority of your patient. You walk in and you see someone sitting in a chair, tripod position, that short word, 2 to 3 word sentences, nasal flaring. They are extremely hot to the touch and dry. Are they a high priority or low priority?
High priority.
High priority. Someone, you walk in, my leg hurts, I fell, and you see some bruising around the knee, high or low priority? Low.
Ain't life-threatening.
Ain't life-threatening. What if your patient in tripod position had normal skin?
I'd still say high priority.
Yeah, there's not really middle ground. They are higher. I might take a minute or two more on scene than I would with the first one, but yeah, I'm still going to consider them high priority.
I mean, in your experience, anytime that somebody is having respiratory issues, and especially in that position like you're saying, I mean, if you can't breathe, I mean,
right.
You can't
now,
live.
I will take a second to figure out if this is a sickness or an anxiety type thing. And what I mean by that is anxiety patients typically have normal skin. And I'm saying anxiety or stress induced or something like that. And I might try to take a minute to say, hey, can we slow your breathing and try to talk them down and see if that helps. But if they're like, I have COPD, or I walk in and they're taking a breathing treatment and they're still doing that, yeah, we're rolling. I mean, I had a guy last week, I think, or the week before. I don't know. It all runs together. We got there. He was having difficulty breathing. He had been to the hospital a couple days earlier and got discharged. Something to note, they had given him a prescription, then the storms came in, so he didn't get his prescription filled, and that could have made a big difference. I don't think this guy was non-compliant. I really think it snowed and iced, and he couldn't get to the hospital to get his meds, so by the time we get there, what they had initially started treating has now progressed. And I wound up, like, giving this guy a breathing treatment and Solumedrol, which is a steroid, and some other like, I went through my entire breathing difficulty protocol with medications because he had gotten so sick. Whereas 2 days, I didn't run him the 2 or 3 days previous to know what the change, but the firefighters did, and they're like, hey, we ran him like 2 days ago. He was not this sick. Mm-hmm. So that's another benefit to the volunteer firefighters. Y'all tend to respond, just, the paid firefighters, they're on a certain shift. So they may not see the same patient. You might see the patient from 3 days ago that I'm here today, and you're like, hey, something's definitely changed between now and then. Or you might pull me aside and be like, hey, this is what it was the other night. Nothing seems to have changed. Just something for you to keep in mind. Do I base my entire treatment off that? No, but do I take your experience in account? Absolutely. So the golden hour, some people call it the golden period. I've heard it called the golden rule of EMS. And it is treatment of shock and traumatic injuries needs to occur. You have an hour for definitive care for the best outcome for the patient. Immediate transport is one of the keys. This is why that auto launch criteria is important. Because think about it. Say we do have a burn patient. The burn sitter is in Birmingham. Who can get there faster, a helicopter or an ambulance? Helicopter. So if they've already been dispatched on this burn, maybe they're getting there and we can get that to go. That being said, use your best judgment for your patient. Don't sit and wait if you can transport and get them where they need to be. And there's absolutely nothing wrong with driving towards someone. So I might drive toward the airbase because I know where the helicopter is, and I'll be like, hey, I'll drive towards y'all meet me in the middle. Or you're on a BLS truck and you need an ALS intercept, I'm going to drive toward you for you to help me. Say you're in Brindley Mountain and you're going to transport to Huntsville. Well, your ALS unit could maybe meet you at 231 and 36. That would, because they could come down 36 and meet you there and take over care. Never be afraid to go toward definitive care. This is just a visual breakdown of the golden hour. How often do you think we actually get a patient to a hospital within an hour of onset of a severe injury? Slim to none. Part of that's because the recognition. How often does someone actually have a stroke right in front of someone else and then recognize that it's a stroke?
Never.
I actually had one the other night, believe it or not. But it's very, very rare. Or think about your trauma patients. How long does it take you to get on scene once you're dispatched?
And then extrication, if extrication has to be done.
And then you got to prep them for transport. And
how long did it take your dispatch center to process the call and dispatch you? And then how long is your transport? Those are all things to consider. So transport decisions are based on patient's condition, availability of advanced care, distance of transport, local protocols. So you're working inside the city of Decatur on a BLS engine and you're dispatched to a wreck, Bravo, with minimal injuries. You get there and it's actually a critical patient. There are no ALS trucks available in the city. One's going to have to come from the county. Do you transport to the local hospital or do you wait on an ALS unit?
Transport.
Just transport. Let the local hospital stable them. They are advanced care to you. They're advanced care to me. They can, at the minimum, start providing care and then arrange a transfer if they needed. History taking. It provides details about the chief complaint and the patient's signs and symptoms. It includes demographic information, including date of incident, their age, gender, race, past medical history, and current health status. One of the things about date of incident, how many times have you run a call or heard of a call where they fell 3 days ago and then called today because they finally started hurting? Is it important to know that they fell 3 days ago? Yes. Karma, you're in the hospital. How many times did they fall 3 days ago and they didn't become altered till today, but now there's nothing we can do because we didn't come in when we first fell?
Yep.
Because the bleed is already too far advanced for us to do anything about. Alright, so we're going to investigate the chief complaint. Make your introductions, make the patient feel comfortable, obtain permission to treat them. Hey, I'm Christy, I'm with the ambulance, I'm here to take care of you. Is that alright? Yeah. Or no. I have had them tell me no. Ask a few simple questions. Refer to them as Mr., Miss, Ma'am, Sir, until they tell you, or their name, or until they tell you different. Ask open-ended questions. This is not your yes-no section. This is what happened. Why did you call 911? Can you explain what you're feeling? I'm really bad about what's going on tonight. I work night shift. I usually get away with that one. Investigate the chief complaint. I put that twice. We'll forget that. All right, OPQRST. OPQRST. Onset. Provocation. It's not going back, but that's all right. Quality. Radiation. Severity. And time. Onset and time are different. Onset is when did this happen, or what were you doing when this happened? Provocation, does anything make it better or worse? Quality, what does this feel like? This is where you're going to get shooting, stabbing, crushing. OPQRST is typically, we ask this a lot with pains. Radiation, does the pain go anywhere? Severity, on a scale of 1 to 10, rate your pain for me. 1 being none, 10 being the absolute worst of your life.
10.
Always 10.
Always 10.
Or 20. I've got 20 multiple times. And T, time, how long has it been like this? Now I will tell you, I may not ask them, and I went again. I didn't mean to. I may ask the question, not necessarily in that order. Now, sample. Let me tell you that sample history is one of the most important things that you're going to do. Signs and symptoms. Allergies. Why are allergies important?
You know what they're allergic to.
So you know what they're allergic to. So you don't give them anything, and so you know if they may have come in contact with anything. M is for medications. And P is past pertinent medical history. Let me tell you a secret. I learn more about their medical history from their medications than I do from anything they ever tell me. Because most patients don't tell you. I can't tell you how many times I've been doing a patient assessment. Hey, do you have high blood pressure? No, I take medicine for that, so I don't have high blood pressure.
It happens.
That one's a common one. Are you diabetic? No, I take medicine so I don't have sugar problems.
So you're diabetic.
I mean, those are the type of things you get.
It may cure your symptoms, but it doesn't cure your.
That I know, but we're still dealing with. That's what people think, though, right? L is last oral intake. Why is this one important?
So you don't overdose them.
Overdose them. What else?
If they have to have surgery.
If they have to have surgery. And do you know why it's important if they have to have surgery? Do you know why they ask that question?
Because it's in their blood.
Aspiration.
Aspiration, because they may have to intubate you.
That's why you can't eat or drink anything
Mm-hmm.
if you have surgery.
So what about like if it's a blood thinner?
That'll be in the medication list. That is important to know. Also, for alcohol. Alcohol can be a blood thinner.
Yeah.
You know, like my patient the other night was dehydrated, and so they gave her a margarita.
No, what?
Yes. I asked the family multiple times, does she take blood thinners? No, she doesn't take blood thinners. So I go to start an IV. It blows. It happens. Her whole arm starts turning purple. And I'm like, are you sure she doesn't take any blood thinners? No, but they may have gave her a margarita. We knew she needed sugar and salt, so I told them to give her one.
Or they Mexican?
Mm-mm.
Oh.
No, they were right down the street.
She runs the county. She don't run the city.
There's still Mexicans in the county.
I know.
But we were in Priceville.
No shit.
Um,
No, that wasn't a no shit as in, like, I knew that. No shit as in.
yeah, you didn't respond to the call.
I
And
think I was at
then
work.
E is events leading up to. So what were you doing when this happened? Were you sitting here minding your own business? Were you outside playing with the kids? Were you and your wife in an argument? Events leading up to. So you've got some critical thinking that you have to do. You're going to have to gather some information. I always joke that my EMS degree came with a degree in criminal investigation and interior design and decorating, because how many times you have to redecorate a house to get the stretcher to the patient. But you're going to have to gather facts, and that's from the people around you. Divide and conquer. You've got a partner, have your partner go talk to the family while you're talking to the patient. Look at the house around you. Do you see anything that makes you think they may have overdosed or come into contact with something? Are they allergic to seafood and you see shrimp on the counter? How about this? Are they allergic to nuts and there's coconut and they didn't realize that coconut was a nut, not a fruit? I've run that call. They didn't realize that eating the coconut was going to make them have a problem. They knew they were allergic to nuts but thought coconut was a fruit.
It's in the name. I mean, I'm just saying.
Or they drank almond milk.
That's funny.
Well, no, they were told they were lactose intolerant, so they needed to get a different type of milk, and they went and got almond milk. Not thinking about, because they didn't chew the nut.
Mm-hmm.
I'm not saying it makes sense, but you gotta,
No, they just milk it instead.
I mean,
I was about to say that famous phrase, but I don't know.
consider what the information means that you've gathered, and then put it together to make a plan. Alright, we're going to do this section, then we're going to take a break for a second. Taking a history on sensitive topics, alcohol and drugs. I do not care what you took, what you drank, when you did it, how old you are. I just want to know to be able to take care of you. I am not the cops. I just need to know to be able to take care of you. That is probably one of the most repeated statements in EMS. I really don't care if you took something, except for I want to be able to treat it if I need to. I really don't care if you drank something. I just need to know if you're going to vomit on me, or if I need to give you medication for it. A lot of times, once the police are not in the back of your ambulance, is when you get the answer to this question. So don't ask this in front of the police. Don't ask this in front of mom and dad. Don't ask this in front of spouses, grandparents, family. Some people don't want their family to know. They're embarrassed. It might be an underage child. They're not going to admit to nothing with mama and daddy there. Actually, I take that back. I ran the one kid that was completely open and honest about everything. She admitted that at 16 she was an alcoholic and that mom bought her vapes because they didn't want her to be just randomly getting them at school and not knowing what was in them.
Well,
They were very open and honest.
I mean,
But that's one out of God knows how many I've run over the years. Do not judge. I'm not judging. I don't care. And if you do judge, don't let them know. But do not judge. We've all had bad days, right? We've all hit rock bottom. We just make different choices.
especially when you get that call at 2 o'clock in the morning for possible cardiac event, and it's just he's having chest pain because he didn't take his anti-acid medicine, and come to find out he's got 2 active warrants, so Price will arrest him right there at Pilot.
Physical abuse or violent, we have to report it all. Read the signs. Typically, domestic abuse is towards a female. Not always, but more than likely. If you think someone has abused their wife, don't ask her if she was abused in front of the husband. This is one of those situations that, I'm sorry, no one rides in my ambulance but the patient. I tend to do that on most everything except for like special circumstances, incapacitated, adult, minor children, that type of thing. But I'm typically not going to let you ride with your wife. That's just for safety issues. But in this instance, if we can separate them, maybe we can get her the help she needs. And do not accuse. But if you do need to involve law enforcement, involve law enforcement. Like, don't go up to someone and say, like, I know you beat your wife. That's a good way to get someone to swing at you.
So if you get a patient like that in the back of the ambulance and, you know, the husband was beating her or whatever, and she admits to you, at the end, do you say, hey?
At that point, I document it.
Report it.
I can, yes. I'm going to report my suspicions to the nurse anyway. But if she admits it, I'm going to talk to the nurse, and we're going to see if maybe we can get her into one of the protective houses or something like that around here, if that's what she wants. Here's the thing. Sometimes they'll admit it and still not want the help because they're afraid to not be with that person. What a lot of people forget about domestic violence is it's not just physical. It's as much a psychological torment as it is a physical. Sexual history. Any female between the ages of 10 and 60 can be pregnant in my truck. Y'all, it's 10 now. I have to look at 10-year-olds. This could be pregnant. I know 8-year-olds that have started their periods. So, I consider childbearing age anyone between 10 and 60. Good rule of thumb. We do not ask 16-year-olds if they could be pregnant in front of their mama and daddy. The answer will be no. Y'all, I have heard stories of teenagers in active labor denying that they are pregnant. It's sad, but it's true. We do not ask, don't ask it in front of the boyfriend either. This is one of those back of the truck, no one else there with you questions. You do need to ask about when was your last menstrual cycle. With men, hey, are you having any urinary problems? The Viagra question. I had a partner ask a man if he had taken any performance enhancers. And he said, what do you mean? And he said, well, sir, have you taken any Viagra or anything like that? You can buy it over the counter now, y'all. There's like an erectile dysfunction cream that you can buy over the counter now.
I was in a double female truck when I got dispatched to genital pain for a male. It was like 49, 52 in that age range. And we asked him, well,